was called yellow.
Go. Okay, everybody, this is Dr. Ed Park from Recharge Biomedical, and today we're going to talk about psoriasis. So let's look at what psoriasis is. Psoriasis generally manifests itself as these plaques, which can be kind of thick red, crusty, sometimes white and yellow patches. They're called plaques, and they occur typically on the extensor surfaces of the arms, as opposed to the flexor surface like the antecubital fossa where they draw blood. That's where eczema or atopic dermatitis occurs. The inside of the thighs or the popliteal fossa, but this occurs on the external, like the knees and the shins. Also common is manifestations on the scalp. Particularly harmful psychologically can be psoriasis of the genitals, and it affects males and females pretty much equally. One of the more serious side effects can be involvement of the joints. So this arthritis can cause pain, of course, functional loss, and deformity, which we'll see an example of in our second anecdote. Factors that worsen and improve psoriasis include moisturizers can make it better. Ultraviolet skin, probably by destruction of some of the proliferative cells, can make it better. Methotrexate by destruction of proliferation, but also impairing of the immune system can be helpful. But as we'll see later, it can also be paradoxically hurtful in rare cases. Biologics are a new class of multi-gazillion-dollar drug, which are meant to impede the general inflammation pathways, and those are generally worked by something called TNF, or tumor necrosis factor, alpha and beta, in this case beta. So at first they had something called Remicade, which was an antibody against tumor necrosis factor, and the new generation is something called Enbrel, which is a kind of like a sponge for the tumor necrosis factor. It's like a false binder. What makes the psoriasis generally worse includes stress and obesity. And obesity, as we learned from podcast perhaps 11, is also inflammatory. Smoking, by a direct cause of nicotine, because it causes a stimulation of the parasympathetic system, also smoking is inflammatory. Skin trauma and scratching. There's something, I don't know if I pronounce it right, it's Koebner's phenomenon, but if you scratch, then you can get, obviously, some breakout. Lithium, which is a divalent cation, or it's like calcium, it causes degranulation or like explosion of these mast cells. So people taking lithium for manic depression can have outbursts. Beta blockers, which is a commonly used drug for hypertension, also decreases sympathetic tone, thereby increasing parasympathetic tone, or the cholinergic system, the relaxation response. And finally, streptococcal infection has been known to trigger, which will be interesting at the very end of this lecture because it points towards a possible evolutionary cause. The epidemiology of psoriasis is that it's been around forever. About 2 to 3% of Western, and I say that because it's more prevalent among Caucasian or European people, is about 10. So we're talking about millions of people who suffer from this. About a third of those could be classified as having moderate to severe. In our two examples later on, we'll see one that's severe and one that's just very mild. Classically, doctors look at monozygotic twins, meaning identical twins, and to see how genetically important or how genetically influenced diseases are, and there's only a 70% correlation. It's not like 100% correlation, as you would maybe get with eye color penetrance. And with dizygotic twins or fraternal twins from two different eggs, meaning SIBs, it's only 20%. So there's clearly something in the development of the organism that's being damaged or altered. And interestingly, psoriasis is not a simple autoimmune disease like classic autoimmunity. You might think of autoimmunity as the body chewing itself up, meaning cells are improperly hostile to themselves, sort of like rioting in London. What we think of it now is more of like a cytokine or proliferative disorder. In other words, is something normal gone wrong? That's what accounts for it being in such a high prevalence in the community. So what's a cytokine? A cytokine means cell movement. It's something that's a signaler that causes a cascade of events or some kind of actions. It's hormones for little cells. And it's a proliferative disorder, meaning the immune response, the inflammation, it seems to be excessive to what's needed. Secondly, there's dendritic cells, which are just antigen-presenting cells. You don't really need to understand what that is. It just means that when bad stuff comes in, the dendritic cells figures out how best to kill. That does by activating off branches, such as the T helper system, killers, and B cells, which is like the antibody type of polio adaptive system. These cytokines are inflammatory mediators. Tumor necrosis factor B, which is the Enbrel sponge. Also important is something called fibrinogen. Now, if you poke yourself right now or scratch yourself and the blood is exposed to the air, you'll start to form a scab. And one of the early pathways of that is fibrinogen. So this stuff is just the universal goop or substance of flowing around your blood and tissue. So it starts to release, and then that starts a process of bringing new cells into there to repair, causing fibrosis. You're already starting to lay down the scar tissue, and then these mast cells, which are like the allergy cells, the sneezing, the itchy, these things are the ones that, if you have an allergic reaction, just explode like sea cucumbers, and they send out all these messengers to start this response. And some of the other degranulation is from what's called polymorphonucleoside. I'm sorry, they're called PMNs. I forget what it stands for. Neutrophils, and it sets out this vast, like, riot squad net to trap any bad stuff and isolate from the rest of the body. Most interesting is this Th1 to Th2 imbalance, which is, it's hard to understand, but I'll explain it later. It's Th1 is killing bad bugs coming in, and Th2 balances it out, so they're opposing forces, and that's more of the allergic response. Anyway, like I said, disclaimer, this is a highly technical talk, but in some ways it's the easiest talk to understand by the end. So classically, we know empirically that giving stuff that kills the immune system helps psoriasis. So one would think that HIV, which is a destruction, an acquired immune deficiency, and specifically destruction of the T cell population, would make it better, when in fact it makes it worse. So that points to something a little more complicated, that it's a dysregulation that's going on. So it's not simply your raw immune capacity that determines psoriasis. They say if you have a hammer, everything looks like a nail. Well, I tend to think a lot about aging, so just kind of pause a moment and talk about a possible aging theory of psoriasis. Now, unlike eczema, psoriasis rarely occurs in young children. Bimodally in the teens and 20s mostly, and then also later in life as your stem cells start to burn out and you're into your older years, then there's another incidence of psoriasis. So we have to assume or conclude that something is acquired in the genetics, which is the DNA, and of course one of the main mechanisms is telomere shortening and then exposure splicing and aneuploidy, which is discussed extensively in other lectures. And then something has changed in the epigenetics. And the epigenetics is a fancy word, but the hottest area in science, and that's the software. So the dogma used to be that the DNA is the be-all and the end-all, when in fact, as we'll see next week or the week after when we do identical twins who are 77 years old, genetics is not everything. In fact, it's like if you bought a computer in 1988 and, the computer was the same, but then you loaded different programs. So far more important, of course, is the epigenetics, the program, the software that's loaded onto the hardware. And that's something that we're just starting to understand. Another thing that kind of just popped into my head was that telomerase deficiency is implicated in a form of idiopathic pulmonary fibrosis. So what is that? Idiopathic means we don't know why it happens. Pulmonary is lung. Fibrosis is turning to scar tissue. So it's like cirrhosis of the lungs. And that kind of just me thinking and leading to a kind of an analogy here. So let's have a basic med school 101 review here. Idiopathic, the professors told us only somewhat facetiously, is a garbage bag term for, well, duh, we don't really understand it. So if you don't understand something, you don't want to say to a patient, it's, I don't know what's wrong because I'm not that smart. You want to say, oh, it's idiopathic. And then, maybe some small people will look up now and Google and say, idiopathic, what's that? Well, it means that I'm an idiot. Or the other two things that they said to attribute diseases to was viral or autoimmune. And that's mainly because you can't really verify these things. It's just a great wastebasket way to explain any disease that we don't fully get yet. So, in general, if a doctor says it's viral, idiopathic, autoimmune, those are all synonymous. Okay? So, but let's look at this psoriasis and what it's associated with. So, psoriasis is associated with a higher prevalence of Crohn's disease, ulcerative colitis, both of which are forms of inflammatory bowel disease. I don't know why they broke it down like that. But then also these other diseases and pulmonary fibrosis. So that's starting to make me think, okay, telomerase, pulmonary fibrosis, psoriasis, what's the possible connection there? Another just bit of evidence or interesting thing to note is that when you look at rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis, these are all arthritides or arthritis diseases, and they show healthy white blood cells. So unlike diseases where we get cancer or heart disease or whatever, you get the erosion of the telomeres, we actually have a healthy immune system, perhaps too healthy an immune system in these conditions, observational. So let's move on now to the red herrings. And what I mean by that is that people have really spent a lot of time researching psoriasis. And the nature of scientific research is that if someone gives you a lot of money and people are working for you to figure something out, you got to have a theory, it's got to get funded, and then you got to devote yourself to proving or disproving, but usually the former, that theory. So everything is very reductionist, and there's not really a way to create a universal logical theory. So you read these papers, and I spent a lot of time in the last few days reading these papers, and basically everyone thinks what they have is the cause when it's actually part of the giant gestalt picture. So let's look into that. Mast cells, as we talked about, are these inflammatory cells which cause you to sneeze, or the dust mites, or if you have a mango allergy. These are the immediate allergic response cells. So we found that mast cells are much more in psoriatic skin. So up here, this is a diagram of skin. Here's the vessels under the dermis. Under the epidermis. And this layer is like a layer of stem-like cells called basal cells. And they're supposed to generate the skin cells, and as you go up, skin cells are supposed to lose their maturity and such. And that doesn't happen in psoriasis. And what's more is that the mast cells migrate up into this area where they really shouldn't be that prevalent, and they start to create their havoc, their inflammation. Something I alluded to earlier was the cytokine release. So mast cells and neutrophils, and the guys who wrote this paper thought, this is it, we've broken through. This is the reason why people get psoriasis, and if we can only target it, we'll cure psoriasis. And of course, that's the great thing about science is you can get to a very precise mechanistic explanation. But when it comes to disease, maybe not. Maybe you're just finding a red herring along the way. So one thing people focus on is IL-17, which is another one of these cytokines, which is related to IL-23. And it's tempting to attribute that, but I believe that psoriasis is more of just a hypernormal response. So this is kind of fun. These cells do this crazy thing where they expel their guts, sort of like a sea cucumber, and the purpose of which is they actually use what they have, which is chromatin or strings of DNA, and these little proteins form the crosslinks of the net, and it's just they cast out this net. And what's shown here is Pseudomonas rods or bacteria trapped in the net. So these little stinkers are trying to keep the infection contained and controlled, and so that's what's going on in the psoriatic skin. Another red herring or something that happens is that you get, again, above the basal layer, remember I showed you that layer, this is normal skin over here, and this is psoriatic skin. You see how thick it is from here, the basal layer up, as versus this? That's because you have proliferation of these cells, and they don't lose their potentiality. They stay very actively telomerase positive and stem-like, and as if they're coming to the scene of a fire and they need to put something out. One thing that I got really excited about a couple of days ago was this MIR203, which is micro-interfering RNA. It's this tiny little RNA that binds to stuff, especially this P63, which is a stem-like marker, meaning like a stem cell or these cells that are packed in here and when they shouldn't be are expressing P63. MIR comes in to turn that off and make them mature like they should, because the reason though you get those big old scaly patches is because you got all this crazy proliferation in the skin. It looks white and yellow and heaped up. So of course people say, aha, we finally found it. This is the reason. MIR203, we need to target that, and that will be the cure to psoriasis. But again, the more I look at this, and a total layperson, I may be totally misunderstanding the whole deal, and people in this field might say, this guy, total layperson. But in my opinion, they all are just part of the whole picture. But again, I am not an expert in this. This is just my crazy musings. So anyway, let's look at our analogous to cystic pulmonary fibrosis, which is characterized by excessive mesenchymal stemness. Again, we talked about mesenchymal stem cells in podcast, I believe, 4 and 5. So what does that mean exactly? Well, when you have normal collagen matrix, and these mesenchymal stem cells, I call them itinerant queen bees or queen bees for hire. They go around and their identity is determined by where they land, and that's determined by the matrix or what kind of milieu they're in. So if there's a bunch of collagen there, they become normal lung cells. If there's fibronectin there, fibronectin is again one of these this glue that comes when you get injury or inflammation. Then what happens is you either get recruitment or dedifferentiation of local cells. So you get all these like stem-like, highly proliferative cells via tumor. That should be TNF, tumor necrosis factor B. And again, I have to say this is boring and very hard to understand, but the end will be worth it because it'll be very easy to understand. But basically, again, you get an excessive amount of more primitive, proliferative stem-like cells. Turning the page now to another one of these things I thought might be, aha, this is the culprit. Again, just another bystander. Is extra domain A fibronectin. So this guy spent 8 years of his life with his other 3 postdocs to prove in London that this kind of fibronectin is a special variant that exists preferentially in psoriasis, and it leads to this cytokine pathway, and the whole, this has to be the cause, right? So kind of like if you look at the London riots and you see somebody breaking a window and stealing a TV, you think, that must be the cause. Well, there are many different things that got that cascade started, and certainly stopping one kid from stealing a TV is not going to explain why those riots occurred. Um, Again, our sister disease is idiopathic pulmonary fibrosis, and we see the same, and I don't know what this means, I'm just pointing it out, that same process occurs. Idiopathic pulmonary fibrosis produced more of this activated fibronectin, again, by the same pathway, and again, tumor necrosis factor B. Getting near the end here. Hold on. So one fascinating study from 1979, I just kind of found this, is that methotrexate is given for immune diseases, and it's also given for psoriasis. But paradoxically, it can cause this weird thing called Hayman-Rich syndrome, which just means really bad pneumonia, just killing the lungs by some weird reaction. So you would think that if it was an allergic reaction, like an anaphylactic reaction, that you would have Th2 dominance or eosinophilia, like a classic allergic reaction, but it's absent in these 3 reported cases. So it could be that it was excessively effective killing of the Th1, which is the basis, we think, of helping psoriasis, is killing this excessive Th1 or bacterial clearing versus Th2 allergic clearing response. And so they just kind of scratch it and say, it's funny, methotrexate killed these 3 people, but it didn't do so in an allergic way. And it did so through this ITP. And so let's turn now to Th1, Th2 dominance. Think of it as like kids on a seesaw. They're balanced. So you want to be balanced. And this is why Th2, which is typically atopy, or the scratching on the inside of the arm, versus Th1, which is when excessive, the psoriatic response. They're not commonly found together. You don't usually get eczema and psoriasis. So let's look at this. The Th1 tend to produce inflammation responses for killing intracellular parasites. Okay. Whereas Th2, as I've told you, is more IgE or eosinophilic or atopic or classic allergic response. Yeah? So we need a balance of that. Here is my gestalt of the whole thing, which is that you get too much inflammation. So it's like you were, to belabor the analogy, it's like someone hit a baseball through a window in London, and all of a sudden the riot squad comes out and starts spraying people with pepper gas and shooting plastic bullets. That's what it is. You have a really good adaptive selected for response that is excessive. So what happens is the fibroblasts are called in. Myofibroblasts, which are a differentiated type of fibroblasts, which is what happens when you get a scar that needs to contract after surgery. That's the one that actually is a muscular type of thing, and it actually brings the wound edges together. And so later on, the myofibroblasts should regress. That's their mission. That's their destiny. But this apoptosis might not occur in certain cases. So, in my opinion, the smoking gun is basically the reason why you can't find one single cause for this. Psoriasis is very prevalent, and so it must be, well, not must, but it might be an adaptation that was selected for in evolution, if you believe in that kind of thing. So, what I mean is, if one of the more intriguing theories here was that streptococcogens, all that come inside and outside our body, but mainly inside, are very similar to these M proteins are very similar to keratin, which is a component of course, the skin cells that proliferate excessively, and also the lung alveoli cells. So it's been thought and somewhat bandied about that Th1 excessive response is because we're trying to clear these strep proteins, and that they just happen to be similar to the keratin. So once you get excessive proliferation of the skin, it's as though you're getting a massive strep infection, so the normal forces come out to fight it. And it's been long known that a strep infection can trigger psoriasis response, which is a bit of clinical medicine that also is now corroborating this highly advanced microbiological explanation. So here, again, 2009, this is 12 years after that theory. Here's 12 years of research showing that, yes, indeed, TGF-beta, fibronectin, all these suspects are there, the usual suspects, but that this appears to be overactive, and again, reiterating that it's an evolutionarily selected for advantage that we're looking at. Too much of a good thing. All right, let's have the fun part now. So that was very sciencey, and even though I created the slides, I already forgot what they said, and I basically don't even understand it. It's very complicated. But I can tell you that people, the nature of science being what it is, people spend a lot of time and money on this and thought, and it's complicated, but it seems to be, by my layperson's guess, kind of a process that's just excessive. All right, well, let me plug in the speakers here, and let's listen to the first patient. And the way this came about, this idea for webinars, is the same as how they all come about. We talk to our patients, and they say, "Hey, this thing happened," and I say, "Wow, can we talk about that?" And that's a webinar. So here's a conversation I had, follow-up a conversation. A gentleman who's 48, and he's had 9 years of knee plaques. A little smaller than this, actually. This is not his actual knee, but something similar. And it was chronic but stable, never took anything for it, and didn't have any associated arthritis. And so this is him talking after 2.5 months.
But long story short, this psoriasis I had for years. I mean, going back, it's probably like 9 years when it started. And so I've had it ever since. And it would sometimes it would get a little bit better, but then it would come back. But it would never go away completely.
So it's both on both knees, but
Yeah.
about the size of what, like a donut or something? Or?
No, probably like a large coin. You know what I mean? It would just kind of...
Oh, small patch.
Small patches, yeah. Nothing real, really bad, like, large. I've seen people with
Yeah.
all up and down their arms and stuff like that.
So no itching, or is it itchy?
Nah, it's just,
Not really?
it would just be bothersome, like, we kind of, how the skin gets scaly and...
Yeah.
And then,
Was it all kind of yellow, whitish, or not to that? Or just
it was more whitish. It looked almost like, if you looked at the actual, lesion or whatever you call it, it almost looks like fish, like fish scales or something.
Right, okay.
You know what I mean? And then they come off and they're kind of painful because it takes, some of the, the good skin with it.
Can bleed a little bit if it goes.
Bleeds a little bit, yeah, kind of stuff. But
nothing in your arms, right?
No, nothing on my arms.
That's good.
But yeah, so
So it turns out you didn't have psoriatic arthritis.
I didn't have arthritis, no, but I have.
That's probably why you thought so, because you looked down at your knees and it was like,
Yeah.
okay, yeah.
Exactly.
Cool.
So I noticed it cleared up probably about a week to 2 weeks after I started taking the TA65, and I thought maybe it's just like one of these things where it kind of it's like abating for a little while, like it
Right.
kind of comes and goes, but
Right.
I've never had it like go away for more than a week or something like that. And to this day, it's completely gone. Nothing. Zero.
Wow, so that's like 2 months now.
Yeah.
And does it itch, or is there anything there? 'Cause
No.
You couldn't tell anything was ever there?
Nothing at all.
Wow,
Yeah. Nothing at all.
that's crazy.
Yeah, it is. It's pretty insane. But
Cool.
yeah, that's gone.
So,
And then I'm sorry, go ahead.
good to hear.
Yeah.
So you never took anything for it, right? I mean, you
No.
never took the Remicade or the Enbrel,
No.
and you didn't put any steroid ointment on it or
No.
anything?
No.
Just left it alone. It kind of left
Left it
you
alone.
alone. Yeah, okay. Cool.
Okay, so that's kind of interesting. The second anecdote, when I call them anecdotes because they're not, case studies. They're not they're testimonials. But I think the biggest knock that people have on TA65 is that they say everything is just anecdotal. And, I don't want to refute that, and that's why the disclaimer here is TA65 is not a cure for psoriasis. It's not FDA reviewed or approved as a treatment for psoriasis, and nothing in this single anecdote or two anecdotes should be misconstrued as such. Improvements in this anecdote may represent a placebo effect or have many explanations apart from telomerase activation. Let's listen to anecdote 2. It's a 51-year-old physician. Let me turn that off. That's annoying. 51-year-old physician, a friend of mine, and he had, at different times in his life, plaques up to 30-40% of his body, throughout his body, painful, itchy, and psoriatic arthritis happened actually in his late teens, and it's progressive to the point where he gets what's called a valgus deformity. See how the foot is turned out at the ankle there? That's just long-term arthritis and physical deformity from that process. Also here in the hands, as a surgeon, this is a problem. He's got wrist deformity, and also see how the thumb doesn't enter the wrist correctly. That's just chronic arthritis. And there's these sock-like bands around both ankles and lower leg, thickened plaques, red, scaly, which have been around since the beginning, 30-odd years. Let's listen to that testimonial. And just to review, he refers to something called Enbrel, which is, as we discussed, a sponge to soak up the excess tumor necrosis factor. And it's an injection given weekly, and one that he required for controlling his arthritic pain.
Number one, the Enbrel need.
Okay.
Enbrel need, the last Enbrel was 2.5 weeks.
So you actually titrate that based on your pain symptoms?
Absolutely, I can. I don't normally. I mean, the dosage of Enbrel is 50 milligrams weekly.
Yep.
Period.
Yep.
Sub-Q. Period.
Yeah.
You don't stray from it. You don't do anything. You just do that, right?
Yeah.
Now, if I in the past have missed it by about 3-4 days, I would notice something. Dude, I went 2.5 weeks and haven't noticed a damn thing.
So what do you mean, like?
The only reason I took it is because it had been 2.5 weeks.
Oh, just because you felt like you had to?
Yeah.
Oh, but you're still pain-free.
Totally.
So if in the past, if you had not taken Enbrel for several days, would you have pain?
Absolutely. Start coming.
Where would it manifest?
In all hands and
Wrists and ankles?
yeah.
Okay.
Yeah.
So that's an active arthritic process for you then.
Oh yeah.
Okay.
Oh yes. Yeah. But the thing is, could it be part of the gluten thing? Could it be TA65? Who knows?
Who cares? As long as you're feeling good.
But who cares, right?
Yeah.
So the other thing is that, of course, the plaque lesions, the psoriatic plaque lesions.
How's that going?
I will tell you that in the last, I've been on your TA65 for a month and a half.
Mm-hmm.
I have not had to apply any topical steroid ointment.
So you use like a clobetasone type of deal or something?
Absolutely. Absolutely. I would need that probably once a week.
Do you
cool down certain areas.
PUVA or whatever that is? PUVA?
Never. No, not now.
That's gross.
No.
Yeah, it's carcinogenic.
Well, I don't need that. I don't need that because I've had Remicade and Enbrel in the past.
And how is the level of the built-upness, or whatever the word is, the height of the
Of the plaque?
the redness and the height of the plaque? Yeah, is that the same?
It's essentially zero.
What do you mean essentially zero?
Yeah, well, essentially zero on the area that I'm monitoring. I mean, the area I'm monitoring is that area I showed you on the side of my butt.
Yeah.
Okay. That's gone.
Is it still there?
It's gone.
Gone.
going to take forever to go away, but I believe they're regressing.
Wow, that's good news.
Yes.
I'm happy for you. Because you never had extensor surface lesions, right? But it's typical really. Psoriasis, right? It's not a variant, right?
Right. But the one that I monitor is the one on my lateral buttock, and that is always needs a steroid topical to cool it down.
So that's more of a direct barometer indicator of the condition of the disease. Yeah, good.
For me it is. And I have not had to apply a topical steroid to that in a month and a half.
Amazing.
It is
right
amazing.
From the get-go, you've had...
That's real.
Right from the get-go, you've had some improvement then. That's good.
Oh, yeah.
So that was interesting. Although anecdotal. So let's just close here with a question. How could telomerase activation alter psoriasis? It's possible that the improved apoptosis is occurring, and again, obesity, webinar 11 talks about that, how that happened with my visceral fat cells, and that you're getting replacement with newer basal cells from newer mesenchymal stem cell candidates. So this system is just younger and better, less prone to whatever messed up genetic or epigenetic problems have accrued. And a clue that this might be at work is that younger is better, especially in psoriasis. You don't tend to get psoriasis in children. You could get, and we know this from the different telomerase activation studies done by Geron Corporation and also in a small cohort by TA Sciences, that the immune system is improved, and in particular thymic cells, but also the neutrophils. Maybe we're getting improved deselection in the thymus. The thymus is an organ which is like a West Point, and the recruits come in and they're selected on their ability to recognize the host, the signal that they're gung-ho, they're killers, but by the time they graduate the West Point, they have to be deselected via apoptosis or programmed cell destruction to not be too gung-ho. In other words, they can't all be these crazy killers, otherwise the body will eat itself in a classic autoimmune way. We could get improved clearance of the antigens, so this whole downward spiral of keratin and strep cross-reactivity, maybe you're getting rid of these subtle strep things, but I don't think that's a huge component. Dendritic cells could be younger and better. We could have improved Th1 to 2 balance, be younger and better. The immune system's getting younger and healthier. And also, one thing that we didn't really get to explore much is these myofibroblasts, these dedifferentiated or proliferative cells. Perhaps the telomerase activity is altered there. And so we get improved apoptosis or decreased conversion of those maladaptive cell types. All right, well, that's it. So 2 guys whose psoriasis appeared to improve just while they were taking this supplement. Again, not meant to imply that that was causative. These are just anecdotes, but I think if you know people with psoriasis, it has a pretty heavy toll, and it's what one of my friends who's a fund manager called it an asymmetric risk. On the one hand, you risk losing maybe $600. On the other hand, you maybe will be one of the people who has some kind of anecdotal benefit. And let's just revisit. I know one of my friends who is involved in funding research for science and was a bit disparaging over all our testimonials on these webinars because they're anecdotes. Let's remember that much of life is lived anecdotally. If we have 2 doors, one with a lady, a pleasant, wonderful woman, and one with a tiger that's ready to eat you, you might not have a randomized controlled trial with 1 million people randomly selected to go through one door or the other. If we look at aging and sickness as that kind of choice, and 7 billion human beings have gone through the one door and got eaten by the tiger, maybe the asymmetric risk of seeing whether these 2,000 folks who've met the lady behind the other door, maybe that might be something to consider. So people often say, well, this is too good to be true. Well, a lot of things are too good to be true, like the internet, iPhones, unconditional love. I mean, if you were to wake up after 10 years of sleep and see these things, you'd be like, this isn't real. People say, well, why haven't I heard of TA65? Well, I mean, it's not for any fault of mine. I've been trying to get the publicity out. But, it's slow because there is really not much of a profit motive for people. We believe it seems to be naturally occurring, hence outside the purview of the FDA. So it's kind of like vitamin C from a plant. It's deemed to be safe at this time. As long as we don't make disease claims, then it's not treated as a pharmaceutical. And there's no company that's really going to pay any money to test it because it can't be owned and patented. Let's open up to questions here. Okay, Jeff asks, how is eczema different? Right, so eczema is, clinically, we've known that eczema is on the flexor side. So it's usually in the antecubital where they draw the blood, or the popliteal behind your knee, those soft areas, and whereas psoriasis clinically is on the other side. Mechanically, functionally, I don't know why, but that's a fact. And also psoriasis can happen on the scalp. Also eczema can happen on the scalp. Psoriasis has more of a predilection for the genitals. Atopy does not, or eczema. But the most important fundamental way is that atopy tends to be an IgE-mediated response, meaning classic allergy. And atopy is usually a triad. We think of nasal rhinitis, asthma, and skin itching. And so that's the triad of atopy, or atopic inflammation, which is a Th2 T helper 2 dominated system. So they're actually in balance. So excessive Th2, you wouldn't really get the psoriasis flare, whereas excess Th1, you wouldn't get the atopy. It's kind of clinical and technical, but I hope that helps. But they're very similar in the sense that they're incredibly prevalent diseases. Of course, eczema much more manageable with with steroid creams and some systemics, but still can be very, very severe. Psoriasis can be of many variants, but they can be very debilitating, both psychologically but socially and functionally as well. So of the two, psoriasis is probably more aggressive and severe, although the kind of medieval methods to control them are similar, meaning immune destruction. In particular, psoriasis is more of the direct skin. They used to paint coal tar on and irradiate people just to kind of nuke the skin, and but that came with its own carcinogenic and bad-smelling Faustian bargain. Okay, so another question here. Kat, to everyone, did both these people stop taking TA65 after 4 months? Well, let's see. Patient 1 has been on for 3 months, and he has incredible testimonials in other areas, topics such as sports injury and depression, which we'll get into. But we'll save that. He continues to take it, and I just spoke to him yesterday. He's doing fabulous. No, he continues. And also patient number 2, the physician, surgeon, he is continuing to take it and has lost 13 pounds and feels fabulous. But again, he also stopped the gluten diet, which has been helpful in his opinion as well. So no, he continues to take it after, I think it's only been 7 weeks that he's been on it. So again, dramatic things. I had a lady in my office yesterday who drove up from San Diego. It's like, been on it for 5 days for muscle weakness. And again, totally anecdotal, but she said, look, I'm getting worse. Look at my hair. Look at my psoriasis in the scalp. And I looked, and since the time she had noticed that she had psoriasis to the time that she let me look at her roots, there was nothing there. I said, where? And she said, well, so, you can be your own judge whether an anecdote like that is of any value whatsoever. But, I mean, it's kind of hard to imagine, fabulate that to that extent. Anyway, other questions? They continue, and that's true, Kat, of most people who take this. As long as the money can be obtained, we don't have a lot of people wanting to get off this stuff. And there's a problem of attribution. I feel better could be diet, exercise, but who cares? As long as you're in an upward spiral, let the placebo effect reign. But you find nobody saying it's a scam. You find a lot of people saying it's not worth the money. But most people can afford it to continue indefinitely, which you could think is a good thing or a bad thing, depending on if you want to be healthy and live longer. Thanks, everybody, for joining in. And, yeah, I know you're probably going to have to listen to this 5 times, who would want to really get what I was saying. I completely forgot already. But bottom line, 2 very interesting cases, albeit anecdotes. And psoriasis is a normal, supernormal adaptation, and one that is a little bit hard to pin down in terms of a single causal etiology. All right, everybody. Good stuff. Thanks for joining in. This is Dr. Ed Park, completing a webinar on psoriasis, and I look forward to seeing you all on a future webinar call. And before August is out, away another bottle. So everyone have a great day. Thank you.
So